This is the Neurosurgery Podcast.
Happy holidays and welcome back to the Neurosurgery Podcast. JP and I have been following events in the news, and it looks like what's been resurrected lately is this issue of Luigi Mangione and the persistence of support for him. Whatever you think of this, it brings to light something very important, which I think most neurosurgeons deal with every day, which is how we deal with insurance companies. And this is something that's really been stuck in most people's craws, especially if they've been in practice for a while. Used to be a surgeon would say, look, I'm the expert, you need this surgery, and I recommend it, and then the insurance would pay for it. That's those are the old days. Those are long gone, especially in spine, but even now in all other fields of surgery, including cranial. So we thought we'd have on the podcast today Greg Basil, who is an expert in this. He's publishing I would call it a seminal work on this, because it is such an important topic. If you talk to surgeons practicing, this is one of the biggest issues they face on a day-to-day basis. So Greg, for those who don't remember you, please introduce yourself again to our audience.
Yeah, Mike, JP, thank you for having me back on. It's been a while. I think I was last on this podcast a couple of years ago in the early days, and it's been amazing to watch you guys grow. And yeah, my name is Greg Basil. I'm assistant professor of neurosurgery at the University of Miami. Kind of before I came to neurosurgery, had a background in finance and worked on Wall Street, doing some work during the financial crisis. So kind of have a broad interest in not just medicine and the practice of medicine, but the economic factors related to it. And I think maybe one of the most interesting things about the conversation we're going to have today is that a lot of the topics we talk about as neurosurgeons, like if you come to one of our cocktail parties and you listened in, it might put a lot of people to sleep. Like it'd be very esoteric discussion of like what surgical technique we're doing, why we're doing it, why it's better. But what we're going to talk about today is something that I think touches pretty much everybody at every walk of life. You don't just have to be a surgeon. Any person that's dealt with a healthcare issue is aware of what we're going to discuss today. And I think maybe the other interesting thing is that when I look at every other of my past research projects, most of them were born out of like excitement about a new idea or a new technique. But this one is born out of actually intense frustration. Right. So it's a little bit different in that regard. And I'm sure yourself and Dr. Colson as well can relate to this. But
yeah, and I love how you use that adjective. I was thinking the exact same one. If there's one adjective or one emotion, I should say, it's frustration, right? Yeah. So frustration is motivating this research. So tell our audience about like how you got started on this research and what your findings are.
Yeah. So, as you transition from, your training to early practice and then, kind of get further along in your practice, one thing that becomes apparent early on is this issue with insurance approval. And what I mean by that is, we see patients in clinic and we've been trained to recognize when they have problems that are surgical. And then we've been trained to know what the right surgical approach is to treat that problem. And so then we talk to the patient about the surgery and then we submit it for insurance approval, right? And then we wait. And sometimes we get approved, sometimes we get denied, and then sometimes it gets kicked down the road. We have a peer-to-peer, it takes a little bit longer, eventually gets denied. So, as I started to turn this problem over in my head, over time, what I realized was I didn't really understand it, and maybe Mike, you could speak to this, but it was hard for me to really know like which of my patients were getting approved, why they were, why there weren't. It didn't seem to be an obvious rhyme or reason to it. And so obviously when that happens to us and we're kind of physician scientists, we're like, okay, well, let's study it, right? Let's look at the problem. Let's understand it better. So that's what we did. We started as a department maintaining a prospective database of insurance denials, really just tracking insurance approval or denial across our department. And obviously my interest, I'm a spine surgeon. I was interested in spine surgical patients. We said, okay, let's look at a retrospective study on a database that was collected prospectively. Let's do a 1-year period, roughly plus or minus. And let's look at what happened in those patients, the patients that were denied and why were they denied and what were those patients, were their demographic factors. And so in our study, that means there's about 740 patients. And when you look at the ethnic breakup, it's something like 88% white/Hispanic. We lump those two together for the purpose of this study. About 5% African-American and a small percentage of Asian patients, right? When you look at their age, they're about 64, which that's not surprising, right? Like most of us, the average patient is older. I always tell my patients, the average spine patient is probably about 64 years old, right? So the study shows that. And then when you look at your insurance mix, this is where it's interesting. And, we can talk later about generalizability of what we found, but, regionally, there's going to be differences, right? So in our patient population here, about 40% of those patients were Medicare patients. The other 60% were private insurers. But I got to put a little asterisk next to private insurer because we know that Medicare Advantage is offered through commercial insurers. So we don't yet have the granularity to pull those patients out. So some of those private patients were actually, probably Medicare patients. And then when you look at how many of these cases were lumbar versus cervical, we're talking for non-neurosurgical, what part of the spine, top or the bottom of the spine. A vast majority were thoracolumbar, about 75%, about 25% of those were cervical. And so now you're hearing me give all this background data. You're like, who cares? What did it show? Right. So what did it show? It showed that, so the insurance denial rate actually ended up being somewhere around 6%. So you guys are probably hearing that and you're probably like, whoa, that's actually not too bad. 6% denial rate, right? So that's the first time I looked at it. I was like, I thought it was higher than that, but it wasn't. It was 6%, right? But I'm going to go into some of the nuance of it. But when you look at that 6%, the first thing to note is that, and obviously this is not, I'm not trying to throw darts at anybody in private practice or anything, but at an academic standard, we like to think our indications are super, super tight. These are all patients who have advanced disease. We're a tertiary center. We're not seeing early pathology for the most part. So those 6% are people that we believe obviously 100% need surgery. Now, we know that spine, there's not necessarily concordance of agreement on every single pathology, but those 6% of patients that are potentially not getting treated that we believe need to be treated. The other important point is that it's not just about whether you get surgery, it's about when you get surgery, right? So that was an important question to us, how long does it take our patients? How long do they wait for surgery? So the average wait time to get an answer from insurance is about 37 days. If you add patients who required pre-approval, it adds about a 9 to 10 day period to how long they have to wait until they actually get to surgery. So from about 44 days to about 53 days. Again, on the surface, you would say, oh, well, that adds, you're talking about a month or a month and a half or maybe 2 months total on average of wait time to get a surgery. Now, again, doesn't sound too interesting, except when you start to understand spinal pathology like cervical myelopathy, for example. We have a lot of literature that says the duration of time that you have symptoms is important. It matters, right? So if you have symptoms for more than 6 months, your likelihood of getting a full recovery of your symptoms decreases, right? And so that 2 months or that month may be significant. It might actually matter in that particular pathology, which leads me to maybe the more important point that I'm going to get to in a second after I go through some more kind of mundane things that we found. So just on the surface, did you guys have any questions about that part of it, or about what we found there?
Well, it's not surprising that you find these delays. I mean, the famous line in the tactic, the delay, deny, defend, that's the was, at least in the past and certainly in the present, the mantra of the insurance companies doing these prior auth reviews. But I I also want to stress that not just in some of these clinical entities like myelopathy, a delay of a couple of weeks or a couple of months to our patients are huge. I mean, imagine if you have kids in school, if you're taking time off of work and you're planning, you're setting up your whole life to take a chunk out of your life to come and have the surgery, and then you find out, oh well, actually it's going to be maybe 3 weeks later than that, and you've already set up all these ancillary and secondary things in your life so that you could take time and come into the hospital and get that done. And also on our end, as the surgeons, we book time in the OR. Then, oh, this case got canceled at the last minute. Now I'm not using my block time. I can't just bring someone else in. So these delays are clinically significant. They're logistically significant for surgeon and patient. But I wonder, Greg, if before you dive into the key findings of your paper, if we could talk a bit more about the role of insurance in general for our patients, because what's interesting about health insurance, and I speaking for a moment too, like you and like I was the medical student who had no idea about this system and is just learning about clinical medicine and how to diagnose and how to treat. The insurance we have in healthcare in the modern United States isn't really insurance, is it? Because you're a finance guy, in insurance, that's for a catastrophe, for some huge rare event that you pay against that windfall. But the way healthcare insurance is used these days in the United States, it's really kind of a all-comer subscription service to the hospital, so to speak. So when we're talking about things being denied or approved by patients' insurance plans, it's not just like, oh, this one black swan rare event, and now they can't get this unusual thing. Insurance is how people access all of their healthcare. So there really is a huge impact to these things being denied for our patients, right?
Yeah, I mean, and I think you touched on a few important points there that I'll try to go through if I can remember them correctly. So the first is that something that I, as I mentioned, have a big interest in, which is that you can't look at things on face value, right? So there's a direct cost and there's an indirect cost. So
Mm,
the economic cost to the marketplace of a person being out of work for another 2 months is tremendous. And I'm not just saying maybe that the denial or the delay from a month to 2 months puts them out of work for 2 months. That might put them out of work for a year, right? Because we
right.
know, Dr. Wang, myself, John Yoon have done a lot of work on objective outcomes tracking. And we know that what your preoperative course looks like can define how you recover. So the longer you have symptoms, the harder it is for you to bounce back. So there could be huge downstream incomes, right? We have to really be like, we always talk about this, but it's like present value of future cash flows. Like, how was that impacted by this? And that is very difficult to capture, right? I cannot capture that in this paper. Maybe they're down the line, we'll try to tackle that and look at that. But the economic impact of this is huge. The other thing that I think you're alluding to, which is correct, which is that people, buy insurance out of a necessity. I think it's different, like you say, than you're buying it like a printer and you're buying an insurance plan if the printer breaks. This affects every aspect of the quality of life. And the way that insurance company views payouts for patients who are sick as operating losses is kind of an interesting thing that's unique to this marketplace. And for the patient, it's their life and livelihood, and for the insurance company, it's a negative bottom line number. And and as physicians, obviously our only interest is in the well-being of our patients. So these factors and these findings that we're kind of uncovering, and hopefully we'll continue to uncover in the future, I think are inherent to the well-being of our entire society, and that's why it's an issue that's so important.
Greg, it's so interesting, right? Like, we go every day to work, right? And we talk to patients, and most of us are primarily paid through third-party payers, whether it be insurance company or the government, right? State government, federal government, DOD, VA system, or Medicare, right? And the funny thing about it is when I talk to patients, I don't think I've ever heard a single patient out of, I think I've seen about 50,000 people now. I've never heard anybody say to me, geez, Dr. Wang, I have really bad insurance, right? They all tell me the same thing, which is, don't worry about it. I have great
Hmm.
insurance.
Yeah.
How is it that the optic is handled? I mean, I'm sure in this paper you got into it, right? How is it that the optic is handled so well by the insurance companies and so poorly by us?
Well, you don't know until you know, right? like, I mean, everybody could tell you that they have the best insurance plan in the world, and people tell me all the time, they're like, "Well, I didn't have pain yesterday." I'm like, "Well, nobody was sick until they were," and like nobody knew how bad their insurance was until they had to use it, right? So it's like that's kind of the thing, and hopefully most people bounce around life healthy and don't need it, but you hope that when the time comes that you do. And by the way, I'm not trying to like put the message out here that insurance companies are all bad, that they don't like that people aren't getting treatment. I'm just saying we need to understand this problem better, and we're not there. Like, this paper does not answer the problem. It doesn't. It probably raises more questions than it maybe gives answers, but it's a starting point. I think we have to look at it, and it's surprising. I think what's most surprising is how little we've looked at it. We talk about it, right? Like, it's like a very common. So then the question is it even hyperbole? We're like, oh man, have you guys noticed denials are getting, or like we get more denials? Is that really true? I don't know, and we won't know until we look at it. So that's really kind of the idea behind this whole thing. So if we can get into it, just yeah, go ahead. Do you have a question for me, JP?
No, I was going to say, please, you telegraphed, and I'm on the edge of my seat for what the meat
Yeah,
is from this paper.
hopefully I don't disappoint you with this. But so, I mean, the first thing is like, what's the payer mix? I kind of spoke to you about that 40% Medicare. When you look at private, Blue Cross Blue Shield is the largest private insurer amongst this particular cohort. It's like 14%. And then Aetna and Humana are the next highest. When you look at the lowest rate of denials, it's Medicare and Humana. Now, again, we have to be careful because, again, vast majority of these patients are Medicare. Even within that private group, some of those are actually Medicare patients. So the number of patients within each insurance bucket isn't that big. So we need bigger studies to be like, I can't tell you that that's actually what we're going to see if we looked at 10,000 patients, just what we're seeing in this particular study. And I think that's important because people who don't do science you know, part of our listeners are going to be science people that are like have done a lot of research, and some of them are not. And if you don't do a lot of scientific research, you do have to explain the numbers and the statistics, right? That like you got a small subset of patients, we can't, it's not sufficiently powered to make like sweeping conclusions. So I'll just say that. In terms of the highest rate of denials, we had Aetna as the highest with 31% and Oscar at like 15%. And then, some findings that are not really, if you look deeper, they're not that meaningful. Like younger patients were higher to be denied coverage, but those are non-Medicare patients, right? And we know that the Medicare patients generally don't need pre-approval. And so then it gets to pre-approval, like 67% of total patients required prior authorization, right? Prior authorization meaning the insurance company has to get the case, you have to review it, you have to say, yes, you're approved for surgery, and then you get it. And then 10% of them required peer review, which again, for the uninitiated, peer review is when they say, oh, okay, we need a peer review, which means you need to speak to a physician at the insurance company to explain the surgery, why it's necessary. A lot of the times that might be like a simple conversation, like, oh, they didn't have an imaging report that you have. Other times they just don't cover the kind of surgery that you do, period, and you can't get it done. And then there was a kind of an interesting finding, which was that 7% of patients had coverage denied in spite of having prior authorization. So that's really interesting. And that's a big source of frustration for a patient. So the patient, they get approval for surgery, you do the surgery, and an insurance company tells them, we're not going to pay for it. Now, I think a lot of those cases ultimately may get resolved on the back end with the insurance companies, but that's a problem, right? And I have in front of me some of those cases. We've tried to look at it and be like, is there something specific about those patients? And it's only 26 patients, so it's not like a ton of patients. Pretty even mix of like lumbar, cervical, some of them anterior cervical fusions, lumbar discectomies, what we would consider bread and butter surgery. Now, why is that? If we look at the reason, so the way we did this study, in a perfect world, I would have the documentation from the insurance company with their letter of denial. That's a little bit tougher for us to get our hands on, and we're working on it. So we have some documentation from the nurse or the case manager who worked on the case. Most of those were denied on the back end in our bucket as medical necessity not established or imaging not sufficient. So what does that mean? We don't know, but it's an interesting place that I think we need to look at. Another thing we found, cervical surgery is more likely to require prior authorization than lumbar, which is super interesting because we think of cervical surgery, again, for the people that aren't surgeons or that aren't medical people, cervical is spinal cord level, lumbar is nerve root level. We always say if a patient has a cervical and a lumbar pathology, cervical needs to be treated first because spinal cord trumps everything. And so the fact that cervical required prior authorization is a little bit confusing, not 100% sure why that is. And then another one, which is kind of interesting, which is that if you had prior surgery, you were less likely to need prior authorization than if you didn't. So in other words, if you'd had multiple surgeries, they've kind of been like, okay, well, this guy he has a good reason. Like, what's the rationale behind it? I don't really know. Okay, but here's the most interesting finding of the study, I think. So we found that the factors that were not linked at all to need for prior authorization were presence of neurologic deficit, myelopathy, which means signs and symptoms of true spinal cord compression and damage, history of a previous PT or epidural, and cord signal change or actual bruising to the spinal cord as seen on imaging. Those were not associated with the need or the lack of a need for prior authorization. So on the surface, that's probably the biggest like scratch your head moment, which is like, okay, we would think that the presence of spinal cord injury or myelopathy would be clearly associated, right? Like you have that, boom, automatic. Like we say that in our field, automatic spinal cord compression with bruising, ongoing compression, that needs surgery. That's one of the few cases where you don't need to be like too thoughtful about it. It's quite clear in our literature, in our training that needs to be treated. Doesn't seem to matter. Now, again, is this a real finding? I don't know. I know that we need to look at this a lot closer. We want to get a much larger series of patients. Want to get several thousand patients. We want to look at this and see if this trend holds up. If it does, it's an interesting question. So then the question is, what is? And that's the big question that hangs in the room that I don't have the answer to. Maybe someone here does, but I don't have the answer to it. And then the final thing, which is that we didn't really see association with demographics. When you start looking initially, you might think there were some demographic things, but they're mostly related to payers. There was some relationship, of course, with what payer you had and whether or not you were approved and whether or not you were denied or whether or not you required pre-approval. So that's kind of the summary of our findings of this study. I don't know if you guys have any questions about that.
Well, it's interesting, Greg, that you mentioned Aetna as one of the outliers for the number of denials. When we were just down in Miami for the wonderful Fellows reunion where we recorded our live episode with Dr. Green, we had an opportunity as part of the program there to talk to the medical director for claims at Aetna. And it was a virtual conversation, but we still, as a group, got to put some questions to him. We talked to him about prior auth, about implant approval and denial, which is often an issue for Aetna, especially ACDF cages. We talked about gold starring. And so I wonder if, as kind of a mini two-part question, I can ask you, putting your mind back to that conversation, now that you've done this study, what would you most like to either say or ask of some of the leadership at these insurance companies now that you've even partially sifted through the data on our end?
I think we want to be fair on all sides of this, right? Again, I don't want to draw, broad ranging conclusions from early findings, but what I will say is, I think the important question is, or really the statement, is that we want to open up the black box, right?
Yeah.
Because that's what a lot of us feel. A lot of us feel that we don't know, that there isn't necessarily a rhyme or reason. And maybe there is. Maybe we're just not aware of it. Or maybe we're just not talking enough. Like maybe we need to be less adversarial and more conversational and have these conversations and talk and say, look, explain to me. Like, and, to be fair, I heard that conversation and I was a part of it. And, part of it was like, hey, if you guys have cases, bring them to me. I'd like
Yeah.
to see them and I'd like to discuss them. I think that's great. I think that openness and that willingness to hear our side of the story and to have like conversations on a high level. Like we don't want to talk we're not talking about peer to peer on a day to day, right? So we also talk about like small impactful things and big impactful things. Like the day to day, your peer to peer conversations, that makes a small impact. Like you're doing what you can for your patients to get them the surgery they need. What you're talking about, what I'm talking about, what Dr. Wang is talking about, like how do we make big impactful changes? And that these conversations had to be had. They're not bad. They don't have to be negative. This is how we open the conversation and say, okay, well, hey, I'd love to see that data. Let's look at some of those cases and let's look into it and figure it out. And maybe it is a documentation thing. And I got to be honest, we know that part of the issue is documentation. They want certain words in there, and most of us are, pretty aware of those things, and we try to, include all the important, points that are relevant to what the patient has done and hasn't done that insurance companies require. But it sometimes seems like a moving target. And, I'm sure they have their rationale. Let's have a conversation about it.
So, Greg, no conversation would be complete without a discussion of AI in 2025, right?
Yeah.
So, we know that the insurance companies have been using AI to review charts. It just makes it cheaper for them. They can review 100,000 pages in a second. And now there's been a lot of discussion. I know you talk to all these people, they're like, we're going to use AI against the insurance companies. Spine section talks about it. I think you've even brought it up. Do you think that it's possible that that will be even like possible in an asymmetric flex? In other words, they have billions of
Yeah.
dollars. We have $5,000. And like, does AI give us the leverage? Does it not matter in AI that the David can beat the Goliath? Or is it that because they have the resources, the AI battle, we're going to lose like 15-0, right? Like, what's your thoughts on this
Well,
about
so
data
this,
science and how
yeah,
this works?
it's a really interesting question. So I think the first thing is how we view it. So I think if we, I could pose this as like a nuclear arms race of AI, but that would paint this out to be like that I want to be very careful because my goal in this paper wasn't to alienate the insurance companies. It was to try to bring them into the fold because I'd love to have those conversations. And we have fortunate, like we're part of academic neurosurgery. We have a large group of people that are very invested and interested in this that are already having these conversations. I don't want to pretend that I'm like, this started long before me, but we want to increase that collaboration between us. Now, if we're talking about like us versus them, like if we're like, and yes, we've had that conversation, like, could you build AI to try to predict like, and you can only do it to a point anyway, right? Because what you're asking is like, could AI help game the system to get a patient surgery? Well, we don't really want to do that because we can't lie. Like a patient has had done what they've had done. And we take that seriously, right? We take Hippocratic oath. I'm not going to lie and say my patient has done PT if they haven't. I'm not going to say they have cord signal change if they don't. So like AI to a point, if you were willing to say anything, maybe that would help because it could like put in like every like symptom that the patient needs to get approved. And like, but if you're talking about just like honestly, like the patient had done what they had done, we can't really change it. And maybe we can massage the language a little bit to make sure it's in the form that they like to see it. Is that going to make a huge impact? I don't know, especially if they're I don't think we all understand this is a dynamic market. It's not static, right? So we talk about it being a moving target. Like what's approved today might not be approved tomorrow. And we also know, like, there's surgeries we do, like endoscopic surgery, that we believe in, that's minimally invasive, that a lot of insurance companies don't like to approve. And I believe that they just, and I think we had this conversation as well with Edna, which is that they may just not just have the literature that we have that shows how good and efficacious the surgery is. So I think the better way forward, I don't think we're going to win that war, which I'm not calling a war, via like an AI arms race. Yes, because if that were the case, we lose. Um, but I think instead, if we can reframe it and say, okay, how do we work together to get the best care for our patients? We're not trying to, as spine surgeons, I think there's a misconception too, like maybe on the insurance standpoint too, that like we're trying to do the honest right thing for a patient, right? Like a lot of the surgery, I'm talking about endoscopic surgery. That's not like a high reimbursing surgery, right? That's a surgery that has a huge impact for the patient with a small economic cost. And so if we all proceed on the assumption that we're trying to do the right thing for the patient, how can we come together and think about what makes sense? Maybe there is, it's not all to say that we're always right. There are surgeons that are performing care that are surgeries that are probably not backed by science, and maybe those shouldn't be being done. So let's talk about the flip side for a second, like, which is like, why do prior authorizations exist? Well, I mean, sure, part of it's cost savings and part of it's to prevent people from getting surgery that maybe doesn't help them, and there can be a benefit of that, right? But it's got to be tempered, and it's got to be, the benefit to the patient has to far outweigh the downside, and I don't necessarily think that we're there yet. So I think we need to continue to advocate for our patients, continue to understand this problem, and we need to do, as clinicians, we need to do everything that we can to get our patients the surgery that they need when they need it, and I think that advocacy can't stop. We all have to be a
Yeah.
part of it.
Well, Greg, I want to give you the last word. And to close this up, I do want to bring the focus of our conversation back to the most important party, which is our patients. You mentioned how everyone comes to you and says, I have the best insurance, and maybe they don't. And as someone who's been through this process where you've had your own patients who have procedures delayed, claims denied, you've had these conversations where you've had to explain it to them. And so we do have now and again patients that listen to the show, and far more frequently, we have students and trainees who are just dipping their toes in the water of that world of clinic where we have to have these conversations as well. So maybe thinking about that scenario where you're facing a patient who's had a claim denied or had a procedure that you know in your heart they need that's delayed, maybe talk a bit about how you broach that topic, how you advise the patient in that setting, either for anyone actually experiencing that who's listening, or for the more numerous people who need to learn how to share that horrible information with their future patients.
Yeah. So it's a great point, JP, and I think that at the end of the day, that's what we're talking about here. I mean, that's the only reason to have this discussion, is how do we help our patients? And so the first thing is, I tell patients, look, this is what I think you need. I can't tell you whether your insurance will approve it or not, but we will be your tireless advocate. And so that's what you need to find, right? Your surgeon is your partner. We don't walk away. The good news is, even if our patients get denials, there is a route for us to appeal that. And or sometimes it's have a peer-to-peer, sometimes it's to do a proper appeal. But what you hear about, the reason that insurance companies have been kind of put on blast for delaying surgeries, what happens is some percentage of those patients just get tired and they say, you know what, I'm just going to not do it, right? And what I tell my patients is, we're not going to give up, right? So if you need this surgery, I will be your advocate. We will do everything we can until we get you approved for the surgery. And I think that falls on us, because that's tiring, right? So we're operating, we're doing podcasts, we're going giving national lectures, we're teaching our residents, and we're dealing with a million insurance approvals. For now, that's just our burden to carry. We have to do that. And you have to be your patient's partner in that regard. And the journey might take you a little longer than you think. It just goes that way, and we'll help you navigate it. That's kind of it. That's all we can do right now. And I think in most cases we're able to find a solution for the patient, but it can be some pain and some time. You just have to not give up. The patients that walk away, and you do see those sometimes, they get denied by insurance and they're like, you know what, I'm just gonna deal with it. And they shouldn't have to. If you have a problem that needs surgery, you should be able to get surgery. And so you just have to have that attitude that you're not going to give up, and this is a righteous fight. I'm not talking about unindicated surgery, of course. We're talking about doing the right thing for our patients. So I'm not suggesting that patients should go out and find a surgeon who's going to do the most surgery and fight tooth and nail to get that surgery they don't need. So find yourself an honest surgeon, which are most of us, I think. And if you believe that you need that surgery, you need to be your own advocate. And patients will do things. They'll hire advocates to talk to the insurance companies. We'll talk to them. Our nurses will talk to them. Our surgical schedulers will talk to them. And we'll fight the battle. That's it.
All right. Well, Greg Basil of Farmer and Hunter fame, thank you for your long awaited return to the podcast. Great for you to come back on and talk about this timely and important issue. Thanks very
Thank you
much.
so much for having me, JP and Mike. Thank you. Take care.